So, our next speaker is Dr. John Mutzeiger. Dr. Mutzeiger grew up in Natchez, Mississippi. He attended Tulane University and then University of Health Sciences in Kansas City. He returned to Philadelphia, Mississippi to practice on a National Health Services scholarship. Meridian is his home and has been since he moved there in 1990. Dr. Mutzeiger has been an addictionologist since 1995 and received his certification by the American Board of Addiction Medicine. He was a previous CME director for the Mississippi Osteopathic Medical Association, that's MOMA, for 7 years. Dr. Mutzeiger is a past president of MOMA and the Mississippi Society of Addiction Medicine. Dr. Mutzeiger has now retired from family practice and is practicing addiction medicine full-time for the Alliance Health Center in Meridian. He just received his fellow status in the American Society of Addiction Medicine this year. And please join me in welcoming Dr. John Mutzeiger.
Good morning. Let me get wired up. And let's see. That was his, wasn't it? Or this is. Okay, today I'm going to be talking about opioids. This is a topic of extreme volatility in America today. I spend my mornings treating A&D patients, detoxing. I detox between 60 and 80 people per month. And in the afternoons, I run a Suboxone clinic. And we have two physicians that do that, and we have a total of about 160 patients. And we can't keep up. That's just the bottom line. We can't keep up. What are our course objectives? Today we're going to talk about the education of prescribers, about the responsibilities, obligations, and management of prescribing controlled substances. Today, especially opioids. We're also going to go over the new guidelines that came out this year from the CDC for prescribing opioids for chronic pain. And we're going to provide a framework for this controversial area and how to minimize the risk of prescribing addictive substances for chronic conditions. What's the scope of the problem? You've heard some of this. United States, 80% of the global supply of opioids. In another previous rendition of this talk, I went through the history of opioids. I've left it out because in reality the opium wars and the history of the world of opioid supplies is interesting, but our problem overshadows that. Average sales went up 402%. Dr. Williams talked about the influence of organizations such as the pharmaceutical organizations. I remember attending lectures and talking about pseudo-addiction. When people escalate the amount of medicine they're taking, they're not really addicted because they're in pain and they were trying to treat their pain. There's been no proof of that. Opioid analgesics are the most misused class after marijuana. It's up at the top. I would say alcohol is the most, and I'm of the category that we look at harm. Alcohol kills the most. Alcohol kills more people than all the other drugs together. Okay? But we forgot about tobacco. Tobacco kills more than alcohol and everybody else. About 450,000 people in the United States every year. Alcohol in the 50,000 range. And then we drop down to opioids. 20% of patients presenting with a non-cancer pain will receive an opioid prescription today. In 2012, there were 259 million opioid prescriptions. What's the cost to society? $500 to $600 billion. This includes lost work, medical costs, and legal costs, and imprisonment costs in jails. Opioid ER visits went up in 4 years, 111%. 14% of adults have widespread or localized pain greater than 3 months. Now, fortunately, I've been in practice 33 years. And I don't remember as many people having pain in 1990 as they are having pain today. I mean, we have created a society of people demanding pain relief. The deaths have quadrupled in 9 years, from 1999 to 2008. More people die from overdoses, from opioids and drugs, than greater than highway accidents. You know, we've got a national highway transit administration that tries to prevent deaths. We don't have anybody trying to prevent deaths from opioids, except a few smaller organizations. In 5 years, or 15 years, there were 165,000 opioid overdoses. They're about 15,000 a year now. In 2013, the DSM mentioned that there were 1.9 million abusers or dependent people. In 2011, there were 420,000 ER visits involving opioids. Therefore, the CDC, on their own and upon prompting from other people, addressed this and released a guideline for prescribing opioids for non-cancer pain. I used to talk about a lot of things about it, prescribing opioids, the opioid categories and all of that, but this talk is a little bit different because of this guideline. So today we're going to talk about the guidelines. And there are clinical questions that come up in these guidelines. They are, what is the effectiveness of long-term opioid therapy or non-opioid therapy for long-term outcomes? What are the risks of opioids versus non-opioids? What are the effective opioid dosing strategies? What is the accuracy of instruments for predicting risk for opioid overdoses? What are the effects of prescribing opioid therapy versus not prescribing opioid therapy for long-term use? So we'll start with question 1. What is the effectiveness of long-term opioids? CDC did a search of the literature. There's no evidence. All studies are 3, at the most 6 months. Now, my profession, I'm at the end of the line. People come to see me when they can't do anything else, when they realize that their disease is killing them and they want to live. There were no studies that evaluated outcomes related to pain, function, or quality of life. Now, as a family practitioner, I've treated people with opioids. I've had diabetics who couldn't take NSAIDs, and they took a Norco in the morning to get up and get going and worked, and took one at night so they could go to bed. And they did fairly well. But it's my personal experience, when a person takes more than 2 pain pills a day, the whole framework changes in their lives. Something happens to them. There were no studies showing evidence for long-term opioid therapy. The body of evidence is insufficient. What are the risks of prescribing opioids? I can tell you about those. 3 to 26% of the patients have the old DSM-4 criteria for addiction. I think it would be higher with the DSM-5. In pain clinics, they say it's 2 to 15%, but I suspect it's higher. Recent opioid use is associated with overdose events. 80% of opioid users who've had an overdose will get another opioid prescription from their doctor. And that's a scary, scary fact. Because they'll go to their local ER, be treated. The doctor will never find out about it. There's no communication between the hospitalists or the ERs with the prescribing physician. There should be some kind of network that anybody who overdoses, there's some kind of flagging that this person cannot take this medication. Recent opioid use is associated with increased risk for any overdose events. Higher doses, higher risk. That kind of makes sense. There's an increased fracture risk for concurrent opioid use. There's also evidence that opioid dosages in the 20 MMEs, and that's morphine equivalents per day, are associated with increased odds of road trauma. What is the evidence for dosing strategies? I get, these little things online that say there's a new long-acting opioid, and we're going to tell you all about the dosing and how this is going to be good for the population. But you know what? There's no evidence. It's better to give somebody a long-acting opioid because they're associated with non-fatal overdoses and overdoses. There's no evidence for comparisons relating to dosage strategies. I was looking through a pain conference, and one of the big talks was risk stratification for opioid dosing. Okay? There's no evidence. 4 studies have shown that the accuracy of assessment instruments for predicting opioid abuse and misuse are inaccurate. There are no studies evaluating the effectiveness of risk mitigation. These include risk assessments, opioid management plans, patient education, use of the prescription medication program data, use of monitoring instruments, more frequent monitoring intervals, pill counts, or use of abuse deterrent formulations for improving outcomes related to overdose addiction or abuse or misuse. What are the effects for opioid therapy for acute pain on long-term use? If a patient gets a week's worth of opioids, and they're opioid-naive patients who have undergone low-risk surgery, it's associated with an increased risk of using opioids over the next year. I can tell you stories of people who said, when I got my knee surgery and they gave me Demerol for pain, I was up and going. People who have the genetics for opioid addiction, just like alcohol addiction, when they receive opioids, their lives change. Early use of opioids for back pain within 2 weeks of an injury leads to at least 5 prescriptions over 2 years. So contrary to what we've been taught by the pain societies and by the pharmaceutical companies, withholding opioids, except for very brief times, is a better idea than prescribing them. So, what are our new recommendations? We're determining when to initiate or continue opioids for chronic pain. What are the opioid selection, dosage, duration, follow-up, and discontinuation, and how to assess the risk in addressing the harms? Okay, so first of all, determining when to initiate. Only when non-pharmacological therapy and non-opioid pharmacological therapy are preferred. I mean, that's first. Don't give them opioids. Okay? You only consider opioid therapy if expected benefits for both pain and function are anticipated to outweigh the risk to the patient. If opioids are used, they should be combined with non-pharmacological therapy and non-opioid pharmacological therapy as appropriate. I challenge you, when your patients come in, especially those who are on opioids, to look to see how much non-pharmacological therapy or adjunctive pharmacological therapy they're on. Because most of the time, I've seen they're on an opioid, a benzo, and an amphetamine. Because when they take large doses of opioids, they can't stay awake. So they need amphetamine so they can work. Of course, they can't sleep, so somebody gives them benzodiazepines. If opioids are used, they should be combined with non-pharmacological therapy and non-opioid pharmacological therapy. Before starting opioid therapy for chronic pain, you must establish goals for all the patients. These are realistic goals for pain and function. And you will discontinue it if the benefits do not outweigh the risk. So anybody has an overdose, the risk immediately has outweighed the further prescription. They should never receive opioids again. Clear cut. Continue therapy only if clinically meaningful improvement in pain and pain and function that outweighs risk to the patient's safety. And before starting therapy and intermittently, clinicians should discuss with patients the known risk and realistic benefits of opioid therapy. I'm telling you now, if you're going to prescribe opioids, you have to give a handout of the risk of opioids. If you don't, that's not the present level of care. It should include risk of addiction, risk of overdosage, risk of taking it with other medicines, and I would have the patient's signature on file. You should have a treatment plan. We'll get into that later. Let's go to the opioid selection, dosage, duration, follow-up, and discontinuation. Clinicians should use immediate release opioids instead of extended release. Why are they approving new long-acting forms of opioids in the FDA? One part of the government saying one thing and one of the part of the government saying another thing. But we should be clinically able to understand that long-acting opioids are not good. And you always prescribe the lowest effective dosage and reassess. Always, if you get to 50 morphine milliequivalents per day. And avoid getting over 90. So somebody who's on 60 of OxyContin twice a day or 3 times a day, that's la-la land. Even though they have tolerance, even though they appear to be doing well. All they have to do is drink or take benzos to die. When prescribing for short-term use, a week is the maximum. A week. You should evaluate the benefits and harms with patients within 1 to 4 weeks of starting therapy. Reevaluate every 3 months. And if benefits do not overcome the harms, taper to a lower dose. So how do we assess the risk and address the harms? Before starting and periodically during continuation, we evaluate risk factors. Now, how do you evaluate risk factors? Part of that's in the history. Now, I was trained as a DO, and the DO profession prides itself on being primary care originally. We have specialists. I'm living proof of that. But you take a history. You take a family history. You've got to ask, how old was you? Do you have a father? No, he's dead. How old was he when he died? 55. How did he die? He was in a car wreck. What happened? He was driving while intoxicated. You got addiction in the family. This is not a good person to prescribe opioids to. Do they have any brothers and sisters who abuse drugs? They're not good. If he's a 3-pack-a-day smoker, he's not a good risk. Clinicians should incorporate into the management of opioid therapy strategies to minimize risk. Minimize benzodiazepine use. I would have said, do not use benzodiazepines. You should review their P&P data to determine what his morphine equivalents are. You should use urine drug testing. You should avoid concurrent opioids and benzodiazepines. Clinicians should offer or arrange evidence-based therapy, that's medicine-assisted treatment with Suboxone, for patients with opioid use disorder. So, there is a formulation on the market called Butrans, which is probably the safest pain medicine to use in people with addiction histories, because it doesn't produce the euphoria, because it's a partial agonist antagonist. So, before we start treatment, what should we do? We should conduct a thorough history, including the substances they've taken before. We can consider using empiric screening tools, which I'll give you one. Evaluate known risk factors. If they're bipolar, if they have an anxiety disorder, if they have severe depression, these are known risk factors for opioid use. You should always consider non-opioids first. You should enhance the monitoring. Always set treatment goals and discuss expectations with the patient before starting opioid therapy. Before prescribing, there needs to be a comprehensive documentation of the patient's pain condition, general medical conditions, psychosocial history, psychiatric status, and substance use history of the patient and the patient's family. How old were you when you started smoking cigarettes? How old were you when you started drinking? How old were you when you started smoking marijuana? Do you still smoke marijuana? Have you taken pain pills before? These are pertinent questions. And use a screening tool, which I'll go to. Get a urine drug screen. Get informed consent. Taper all benzos first and obtain a prescription monitoring report. Now, I have seen my Suboxone patients in my addiction practice go to pain treatment centers, and there's a Suboxone prescription on their report, and the pain clinic gives them a prescription for extended release morphine and Norcos. Now, I don't understand that. This is an opioid addict, and they're being treated by a pain clinic for pain. And that's kind of in the hazy area these days. But it just makes me wonder. During treatment, when you begin a trial, you should reassess in 1 to 4 weeks. And you have to routinely reassess every 3 months. You document the therapy, you document the efficacy, you document the adverse effects, any evidence of misuse, and evidence of benefits overshadowing risk. Obtain another PMP, urine drug screen. Address, evaluate, and respond to questionable use, which I'll also go into per policy. Discontinue if no benefit or risk overshadow benefits. Evaluate behavior and determine course of action if questionable use occurs. If the wife says all he's doing is lying around on the couch watching TV, he's probably over-medicated. Address questionable use with the patient. Reevaluate benefits and risk. Continue referral to addictions. Consider referral to an addiction specialist for consultation. And initiate an opioid taper if discontinuing. Consider addiction consult if SUD is present. Most physicians say you screwed up, you're fired. CD says initiate an opioid taper. Because what are these people going to do? They're going to go find opioids somewhere. It might be fentanyl in the Norcos that they're buying on the street and they overdose and die. And if I was a lawyer and had that, and they just fired them, that right there is the ticket to sue. I don't get many referrals from pain specialists saying, this guy screwed up, please evaluate him, taper him down. I just don't. But I get them 2 or 3 weeks later saying they've been fired and they're now taking opioids off the street and they don't know what to do. Back to the history and physical. Cause and nature of the pain. Past treatments. What has the patient tried before? If he's tried opioids before and failed with another physician and been fired, it's probably not a good idea to give him opioids. What are the tests he's had? Medication trials. The patient I always hated to get was, I've got shoulder pain, I've got to work, but I can't afford an MRI. You think he's working you? You know, you can't treat these people. If they're not willing to be tested and evaluated, they're not able to receive opioids. You estimate the pain level and its intensity. That means you watch them walk out into the parking lot afterwards. You watch them walk into the hall. And you have to have nurses who say, man, he plopped down in that chair and then he got up, and no appearance of any back pain. Psychological history includes living arrangement. Does he live by himself? That's not a good risk for taking opioids. Family, social support, work status, and family obligations. The psychiatric status should include psychiatric disorders and treatments and family history of psychiatric disorders. If mother and father were both bipolar, he might be looking for opioids to moderate his own bipolar. The substance use history should use current, past, and family history of substance use and abuse, addiction, and treatment for addiction. Documentation. And if you ask patients, have they ever been treated for something, they usually tell you. And the records I get have none of these records. Now this is a good little one-page screening instrument. It's called the SOAP SF, Simple Form. There are 4 columns. They're never, seldom, sometimes, often, and very often. And the questions are 6. Number 1, how often do you have mood swings? 4, very often. Patient is excluded. You don't want to be giving opioids to a person who has untreated and non-controlled mood swings, because he'll medicate his mood with opioids. How often you smoke a cigarette within 1 hour after you wake up? This is one of the greatest screening questions known to us today. Because if they get out of bed and have a cigarette, that's evidence of a pretty addictive personality. Every day. Once again, a 4. A 4 is a positive screen, by the way. How often have you taken medication other than the way it was prescribed? How often have you used illegal drugs in the last 5 years? How often in your lifetime have you had legal problems or been arrested? Have you ever overdosed? So when are opioids indicated? Pain is moderately to severe. Significant impact on pain or function, on quality of life. Non-opioid therapy and other therapies have failed and is documented. Patient is agreeable to have opioid use closely monitored and understands the risk and benefits. Better have it in your record. You, the prescriber, determine that the risk is not elevated. So you should have some means of excluding people with higher risk. Tramadol is the only narcotic that's proven to help fibromyalgia. So all other narcotics should not be used. How often have you seen that adhered to? Diabetic neuropathy. These are opioids that they do help. Peripheral neuropathy, post-herpetic neuralgia, phantom limb pain, spinal cord injury with pain below the level of injury, which is phantom pain. Lumbar radiculopathy, osteoarthritis, rheumatoid, low back pain, neck pain. Where can we find these guidelines? In Mississippi, it's the Medical Practice Act of this Mississippi Code of 1972. You can go online at the Mississippi Board of Medical Licensure. They also have a jurisprudence handbook they'll send you. And you can also go online with the morbidity and mortality report where the CDC published the guidelines for prescribing opioids for chronic pain in the United States. The history and physical should be good faith. Evaluation should be there. Treatment should be diagnosed. Documented diagnosis, not because they tell you they have a herniated disc, but because you have proof they have a herniated disc. The reason for prescribing should include the date, name, dose, strength, and quantity of the drug and its refills, and you maintain that record for 7 years. What is lack of good faith? Doc, I don't like the Norcos, but I like the Tyloxes. And you write Tylox. You allow the patient to name the desired drug. Dispensing drugs when you should have known he was an addict. Now, when I worked for Rush Hospital, all of the clinics had a shared system, so I could see what everybody else did. I was the only addictionologist in the system. I would prescribe Suboxone, or I would taper people off for benzos, or do short tapers off of opioids because they were addicted, and it'd be in the chart. And I know why people didn't look, because it's so hard to find in a computerized record what other people have done. But if it's in the record, and then you prescribe an opioid to an opioid addict, you should have known. And Mississippi law, they can come after your license and take it away. Repeated refills despite non-compliance. If you ever endorse non-therapeutic uses of medicines, or you prescribe contradicted medicines, amphetamines, and benzos. So the administrative code definition of chronic pain used to be more than 6 months, but I suggest to you that it is now 3 months. It does not refer to chronic terminal disease pain, in other words, where life expectancy is less than 6 months. You may use controlled substance to treat chronic pain, but you should use caution. You always have a risk-benefit analysis. You review prior records and treatment. You need proof of indicated need for long-term therapy, not because the patient tells you. You have a documentation of complete medical history examination and treatment plan. Review and document every 3 months or less, including modification of therapy dependent upon completion of treatment objectives, and referrals and consultations as necessary. So your written treatment plan should have a stated objective with how you're going to measure it, your diagnostic planned evaluations, informed consent, use of one physician and one pharmacy if possible, use of urine drug screens when requested, PMPs every visit, and recorded 4As of every visit: analgesia, activity, adverse events, and aberrant behavior. Now, there are 2 types of aberrant behavior. There are yellow flags and red flags. Yellows is not as bad as the red, just like in soccer. 2 yellows, you should be out. Complaints about the need for more medicine, hoarding drugs, requesting specific medicine, openly acquiring medications from other providers, occasional unsanctioned dose escalation, and non-adherence to other recommendations. What are the red flags? Deterioration in work or social functioning. Illegal activities, you read about them in the paper, that they were arrested with methamphetamine. You know, they've been selling, forging, or buying on the street. They're snorting the drugs or injecting. Multiple episodes of lost or stolen. Resistance to change in therapy despite adverse effects. Refusal to comply with urine drug screens. I have a shy bladder. You know, you can do mucosal swabs and send them off. But we tell them, just sit down. You'll eventually have to go to the bathroom. And we'll just keep giving you something to drink. And you know, they have to go to the bathroom after a certain amount of time, or they don't get their prescription. Concurrent use of alcohol or illicit drugs. Now that means your urine drug screen should have an area that picks up alcohol. If you don't, you're missing people who are drinking and taking their narcotics. And these are very sensitive. If they'll have a couple glasses of wine and come in 3 days later, you'll know they've been drinking. Use of multiple physicians and pharmacies, or anytime they use adulterants, or you get a positive pregnancy test off of the male's urine. You have a use agreement. You monitor behavior. You monitor adherence, addiction, and diversion. Initially small quantities and frequent visits. Another PMP. You should discuss the monitoring with the family. You need somebody to tell you how the person's acting. I was in a part of the state where when the coal plant came in, there was an ungodly number of people from out of town who came in requesting narcotics and amphetamines. They're from South Dakota. You know, I've got a bad knee and I need to work. You know, it was, and large projects like this will bring them out of the woodwork. So these are some pearls from years of practice. If you treat somebody with small amounts of narcotics, they get better quicker. Anybody know why? Because if you don't screw up their own pain treatment system within them, the pain goes away. I'm convinced, without a doubt, especially because of paradoxical hyperalgia when we give people Norco and other pain medicines, that we're creating a bunch of people with pain. And I agree, they're in pain, but we've got to stop causing the pain. You know, think back. Before the 1800s, there were people with pain. How did they live through it? Their systems adapted. The brain is able to take care of pain chronically by adapting. And if you give them narcotics, they're not going to adapt. People with addiction never notice a small increase in the drugs you give them. They're after a big increase. If it looks like an addict, asks for more drugs, and even demands it, it's usually an addict. If the dog ate the medicine and the dog didn't die, probably didn't eat the medicine. Concurrent use of recreational drugs with pain meds is the mark of a polysubstance abuser, and he doesn't need to be on narcotics. And we all know there are hundreds and thousands of people smoking dope. And they can do what they want to, but they can't do that and take our medications. I kick people out of my Suboxone program because they smoke marijuana. How can you endorse getting off of one drug and continue to smoke another one? Anxiety is treated with antidepressants and not benzos. My next talk is going to be on sedative hypnotics, and one of my biggest complaints and soapboxes is nobody knows how to treat anxiety in our society without giving somebody long-term sedative hypnotics. And trust me, Paxil or Lexapro or Celexa or one of the other antidepressants and one of the old tricyclics together with it will treat any anxiety you find. I've taken people off of 20 to 30 milligrams of Xanax a day and treated them with that combination. And these are people who couldn't leave the house because of their anxiety. They couldn't grocery shop. And now they're living normal lives. Paxil, 40 milligrams, maybe a little Pamelor 50 at bedtime. And they don't have anxiety anymore. The later in the day or closer to the weekend the patient calls for more refills, the more likely he's abusing. Now, we all know that. And there are no shy bladders amongst drug users. Lots of little old ladies make their living off of the prescription that you're writing, so be suspicious. I remember one little lady, and I thought it was funny. She was coming from Starkville. And fortunately, the PMP was out, and we ran a PMP, and she was getting medicines on one day in Starkville, the next day down in DeKalb, and then she'd hit Newton, and then she was hitting me, and then going back to Philadelphia. And she had a stack of records. So my corollary is if they show up with a stack of records, that should be a warning point. Now, not all of them will be, but it's like they carry them as a badge. I hurt. Boom. There it is. You've got to start at the beginning. You should never give them opioids the first visit. But I'm only in town for 3 weeks, doctor. They made a bad choice. Excuses excuses are what will get your DEA taken away. Do not write opioids for a patient after an overdose unless you want to be sued when he dies. You should have a nurse in your office who knows your patient base and has a nose for BS. I work in Decatur, and I had two little nurses who were in Decatur, and they knew everything that went on. They had scanners they listened to at home, and I'd come in on Monday morning and they tell me, so-and-so got arrested, so-and-so's in jail, and so-and-so's selling his prescriptions. Well, it makes my job easy. You've got to call other doctors and find out why did they leave. Because usually they're fired. And if they've got Suboxone on the PMP, they're probably an opioid addict. Unless the person prescribes you tells you otherwise. There are a few people who take Suboxone for pain, but they shouldn't be wanting narcotics. These are my references: Principles of Addiction, The Prescription Drug Crisis, some of Scott's lectures, the Utah guidelines, the FDA blueprint for prescriber education on long-acting and extended release, Prescribing for Pain by Dr. Alford, substance abuse, a textbook, and the CDC guidelines. I'll open it up to questions.
I should have asked the anesthesia guy, but nicotine in the old days, of course, I'm 77 years old, so orthopedic surgery, of course, trauma's fine. So at the time I see people, they got something wrong. This is one of the best lectures I've had in a long time.
Thank you, sir.
The combination of cigarette smoking and pain medicine, Tulane's working on it, doctor over there with in the brain. So if somebody comes in, it's a heavy smoker, and then either I've got them from somebody else, and then on a high level of, narcotics, 10, 10, 10, and all that. Nicotine interferes with pain medication, but I don't hear that preached enough.
The other thing is the nicotine creates a higher level of CO2 in the body, and that prevents healing. And I know several neurosurgeons who will not do surgery if the patient will not give up the smoking because it increases the odds of a failed surgery.
And long-term spine surgery, I'll tell you, we knew about that 20 years ago, and I say 10, 12 years, Texas Back Institute won't do it. High smoking interferes with collagen. Dr. Charles Mary, famous in Louisiana, who Linus Pauling, vitamin C. You have to have vitamin C to get the collagen to lay down. And an orthopedic have collagen for tendon, ligament, bone. So when they throw smoking in there, they're fooling up the whole network. So what you've just said is absolutely it. Neurosurgery, and we had to teach the neurosurgeon how to fuse. So I'm glad to hear they're knowing.
Thank you. The question was the relationship between nicotine and non-healing. Sorry, I didn't go over that quicker. Other questions? Yes, ma'am.
You mentioned the proof of indicated need for long-term therapy. What is that?
Well, somebody's in a wheelchair. He's got a L3 transection of the cord. He suffers from phantom limb, chronic pain, spasms, etc. That's proof of long-term need. People who have transected cords have pain below the level. It's documented. Okay, you might witness the muscle spasms, but that's what you need to put in the chart, And you need the records. Where did he have his surgery?
I think most patients in a chronic pain clinic don't have transected cords.
I agree.
And a patient that has, let's say, 3 disc protrusions with Bramall and central canal stenosis who can't walk, is that proof?
That's proof, But the question I'm going to ask you is, if you're a family practitioner or an internal medicine doctor, do you want to practice prescribing pain medications for your patients? Because I've shown you there is a proof of intent, deliberation, etc. on doing this in order to keep doing it. And there are patients who need this. I'll be the first to agree with you. But I'm telling you that most of the people that I see, I'll give you a recent example. A patient had an emergency surgery for a clot over somewhere in the thoracic spine. She was taken to surgery. She developed an infection. They went back in. It ate away some bone. They went back in, put in some hardware. Then the hardware got infected. They went back in and they took it out. And this whole time she was on narcotics. Okay? Well, she ends up for detoxification because she's overdosed several times. Now, I understand the doctor's treating the pain. But the records I've seen, nobody asked whether her mother or father were addicts. Okay? And they were. And she, until that point, she'd never taken opioids. And here she is now an opioid addict, created by doctors, necessarily, I agree, but then they fired her. You know, this is a mad woman. I don't know about y'all, but when women get mad at you, you better watch out. You know, men get over it, but women don't tend to get over it as easily. But, you know, I put her on Suboxone. You know, she's got a wound when I'm detoxing her. You know, and this is a difficult patient. But what I'm saying is, somebody should thought, now if we're going to treat pain long term, is it better to use an agonist-antagonist, or to use butrans? Because you don't get the changes. And the more time she takes medicine, the more likely she's going to become an addict. And you put somebody in a butrans patch, they don't develop the craving as well as people who are on long-term, just pure mu agonist. So the people prescribing the pain medicines need to think about the situations. And I know these neurosurgeons were worried about a suit, which makes us more likely to prescribe pain meds because you don't want to piss off the patient. You know, but this is not, how do I put it? This is not a easily done thing. Okay? Yes, sir.
Can you comment in your population on the use of Voltaren gel or Cymbalta?
Yeah. The question is, can I comment in my population on the use of Cymbalta and Voltaren gel? Well, Voltaren gel is good for joint pain, especially, and it can be good for post-herpetic neuralgia. It's also good for specific little interphalangeal joints, that type of thing. I have, I forget the name of the disease, but I have bridging osteophytes in my thoracic spine. I have, my father had it, I inherited it from him, and DISH, diffuse interosseous systemic hyperosteosis. I just like to forget it. And I went to a pain clinic in Meridian because I was having pain in this area. And it happened after I slept on my stomach one time. I hadn't slept on my stomach in years. I lost some weight. I fell asleep, slept on my stomach, and I woke up hurting. He gave me a trigger point injection, and I wore a Voltaren patch. And it went away, okay? Personally, it's a success story for me. And the other one was Cymbalta. I think Cymbalta is overrated. If you're going to use Cymbalta, you probably need another antidepressant with it because it's not that great an antidepressant. It can help. But the biggest changes I've seen, and this is an addict population that I'm detoxing people, and I take them off of all narcotics, and I usually treat them with a non-steroidal, and I like Xanaflex at bedtime, 2 to 4 milligrams max. Physical therapy, etc. When you get them off of the pain medicines, they all seem to get better. Now, there's maybe 1 out of 100 or 1 out of 200 that have, you know, cervical stenosis, and they're in terrible shape, you know, and that's a pain clinic patient. You know, but I don't need to be treating that patient. Okay, we all suffer from which syndrome? Because we're physicians? Savior syndrome. We want to help somebody where nobody else has helped them. Okay? Nurses do it too. We should question our motives. Yes?
Yes, sir. According to the new statement in this little handout, it says people who take prescription painkillers can become addicted with just one prescription. Can you elaborate on that?
Yes. The question is, can you get addicted on one prescription? Yes. I do, in the hospital and addiction, I do drug histories. How old were you when you opioid addict, how old were you when you took your first opioid? Well, I had knee surgery when I was 33. And they made me feel better. And I went back and got more prescriptions. And pretty soon they were buying them on the street. There are cases of people becoming alcoholics after the first drink if their disease is so bad that one episode of drinking expresses the disease. Usually alcoholism takes 10, 15, 20 years to express. But opioids addiction expresses in as little as 6 to 12 months, just like cocaine addiction, just like methamphetamine addiction. So we're not talking about long periods of time. You've got to be careful. And my father was a family practitioner. He wrote Tylenol number 3 all the time. Tylenol number 3 is not a pleasurable drug. It's a great drug for pain. Norco has a ceiling on pain effect. But they're putting it in huge doses now. What does an increased dosage of Norco do? It increases the euphoria. So most of the time we're treating euphoria or lack of euphoria rather than pain. And you've got to ask yourself, am I treating a disease, addiction that I don't know about, or am I treating chronic pain? Yes, sir.
What about intractable cough and some of the daily things we see in clinic, a nighttime cough dose?
Well, the first thing the question is, how do you treat intractable cough?
And one with codeine would be preferable over hydrocodone.
Yeah, one with codeine would be preferable over hydrocodone. Get rid of the Cozar, get rid of the Zestral, because Cozar will do it just as much as Zestral will. Are they microaspirators? One of the number one causes of chronic cough is microaspiration. Send them to the pulmonary specialist, send them to the GI. Okay? They may need a chest x-ray. You may have something going on in their chest that's making them cough. It's easy to write a prescription and keep writing it. We as physicians are known for rewriting prescriptions because he was already on it. But I think we should question each and every prescription when we see them. For instance, I get alcoholics who are on 3 blood pressure medicines. And I take them off all their blood pressure medicines and put them on PRN clonidine the first 24 hours. And usually after 72 hours, they don't need a blood pressure medicine because their blood pressure has been driven by their alcohol abuse. Ask them, how much are you drinking? Rather than putting them on another blood pressure medicine. Hope that helps. Yes, ma'am.
I'm not sure how to ask this, but I'll speak a case. I have a patient who's like early 40s who's had extensive lumbar fusion. And he responds sometimes to various blocks or spinal procedures. But he also continues to insist that he requires 3 to 4 Percocet 10 a day in order to sleep or live. And he also smokes a pack and a half to 2 packs of cigarettes a day, which I always get on his case about. But is there, with all the smokers and people in pain, if they come in and want to get better, and I think the first thing they need to do then is stop killing yourself with cigarettes. But would it be reasonable to say when you back off on smoking, we'll continue pain medicine, or if you don't stop smoking, we're going to stop the pain medicine?
The question is, what do you do about people with good reasons and causes for pain who also smoke? And the way I've always handled it is, part of my treatment is you to quit smoking. You have 3 months to quit. If you don't quit, I'm stopping your narcotics. You can find somebody else to treat you. And I tell you, when that 3rd month comes, they get, I need to quit. Okay? I do the same thing with people who are 350, 400 pounds and have terrible osteoarthritis and want to take pain pills for their knees. You've got to lose some weight. Just because you're making yourself fat doesn't mean I have to give you narcotics. Just because you're maintaining your pain with tobacco doesn't mean I have to keep giving you pain pills. We have a choice.
After 3 months, do you stop it or you taper it?
I taper. I always taper. And folks, there's one of the greatest tapers in the world. You know, especially in the hospital. You know, somebody's on narcotics. And listen, if you're surgeons and you're operating on addicts and you know it, you've got to get them off the pain medicine before they leave. 2 milligrams of Suboxone every 6 hours for 1 day, every 8 hours for the next day, and every 12 hours for the next day, and stop. And they are tapered. Anybody can taper. It's a 3-day prescription.
To give Suboxone, or just because they're
Opioid replacement therapy requires a X number. If you're tapering somebody in the hospital, you do not require it.
Can you repeat that taper?
2 milligrams of Suboxone or Subutex every 6 hours the first day, every 8 hours the second day, and every 12 hours the third day. And typically I give them a little clonidine, 0.1, up to every 8 hours if they've got a blood pressure that can sustain it for any withdrawal symptoms after they leave. Yes, sir.
I have a question about the rules and regulations talk about not being able to use opiates, treating somebody with an addiction problem, either for detox or for maintenance. Unless they have a waiver, a DEA waiver. So can you clarify the difference between detoxing in the hospital versus in the clinic, which would require an X number?
Right. In the clinic, you need an X number. In the hospital, because the hospital has a license to prescribe narcotics, you can treat addiction in any hospital in the United States that I know of. You're allowed to detox people with Suboxone, just like if you have somebody come to you in the hospital and he's had an acute appendicitis and he goes to the methadone clinic in Alabama. You call the methadone clinic, you confirm he's taking methadone, and you can write methadone in the hospital for him. Okay? You know, it's the same thing. We can treat people and their diseases in the hospital where we can't do it outpatient. Yes, ma'am.
So for people who, going back to this whole case, people who sign a narcotics agreement or contract with you, and then find out they're getting medicines from multiple different doctors, I mean, would that be appropriate to, are you saying we should taper those folks?
Well, let's see. If you're writing a lot of narcotics, you probably ought to have an X number so you can detox people with Suboxone off of opioids. That would make sense to me. You know, I was brought up and educated in the time, you don't do something if you can't treat the consequence of your treatment. You know, they frowned on family practitioners doing appendectomies because if they had a complication, they had to send them to the surgeon. And we all know what the surgeon was going to say. Well, in my profession of addiction, we addictionologists say, well, if you're creating problems, why can't you treat your problems? Or at the very least, have an addictionologist you can call and make an appointment in the next 24 to 36 hours with your patient. Or you can taper with the opioids that you're also prescribing. I mean, you know, it's 9 Lortab 5s is not a big dose, 4, 3, 2, or a day's worth to get him to see somebody else.
So if they're seeing other, say you check with PNC and they're seeing other physicians, not, I guess, liable?
Well, you can't keep treating him for chronic pain. If the PNP says he's broken and he's broken in the agreement, but say he's got, but what are you going to do? You're going to tell him leave? Or are you going to find someone to take care of him? You need to be able to offer, I can send you to somebody for detoxification. And I don't get many calls for that. Because I hear the stories from the patients who get cut off, and then that's when they find out their first cousin gets 90 Lortabs or Norcos every month, and they call them up and they get 45 of them, and then they say, but you got to give them back to me. So they got to go find a doctor to give them Norcos so they can give 45 back to their cousin. I mean, people are breaking the law all the time when it comes to narcotics. You know, they don't care because they're just trying to maintain. Yes, ma'am.
Do you know about Lyrica controlled and Neurontin is not controlled?
Yes, ma'am. Why is Lyrica controlled and Neurontin not? Because Neurontin wasn't controlled and they came out with the same thing. It's a little more potent. They controlled it. They learned from their first one. They can't it's hard to retroactively change Neurontin. In an addiction setting, the only times I use Neurontin is with documented neuropathy. I mean, real neuropathy. Number 2, we occasionally use Neurontin for alcoholics because it can dampen the craving in alcoholics. And you use that not first choice, but later on down the line. So, yes, ma'am.
Any comments on the abuse deterrent technology or abuse deterrent formulation of long-acting opioids or even immediate-acting opioids? The FDA sort of requiring this now, and supposedly going to phase out immediate release or long-acting opioids that don't have the abuse deterrent formulation.
Well, the question is, what about abuse deterrent forms? I've yet to meet an abuse deterrent form that an addict can't figure out how to take. They can always take it by mouth. You know, that's the very least they can do. You know, it's nice that they can't shoot it, but they'll take it by mouth if they can't take it any other way. So there's no such thing as a non-abuse form of a narcotic.
This concomitant use of Adderall, which everybody's even asking for now, does that contraindicate with pain medication in general?
The question is, what about Adderall and opioids? If you're going to prescribe the two together, you better have good documentation, I think. I think there probably are some people, but I think they're fewer than we think. And if they're on opioids, are they working? Are they driving? Are they, if you're giving opioids to nurses or doctors or people that drive buses, airline pilots, EMTs, and all these people with licenses, what's your exposure? if they're working and you gave them a go back to work and they're still on narcotics? So if he's taking opioids, he probably doesn't need to be taking Adderall because he shouldn't be working, especially if he's got a license to do something. That's my point. So if he goes back to work and needs to take Adderall, he needs to be off the opioids. That's the way I get at it. You're welcome. Yes, ma'am.
How accurate do you find the urine drug screens are?
The question is, how accurate are the urine drug screens? Very. You know, the confirmations on a good one, Callaway is a good one. There are several other ones. Millennium's another good one. Confirmation is done by gas chromatography. Gas chromatography identifies the chemical structure. If they find it, it's there.
So you go based, like, say you get like a weird false positive, like, would you go and confirm it like that?
Oh, yeah. For instance, PCP and we'll get a false positive for dextromorphan. Okay, so if you get a dextromorphan and the PCP is likely, but if they do the gas chromatography, they'll find out it's only the dextromorphan. Dapro, an old NSAID, gave false positive for benzos. So if you're just using the 14 cup, you know, if you get a positive and you're going to base a decision on it, you need to get a confirmation. I better shut up at this point. I thank y'all very much.